is Jessie Phipps from CPR Kids, and she's going to take it away. Thank you.
Thanks so much, Paul. Thank you for having me, everyone, and thank you for joining me on this very chilly night. I appreciate it. So now Paul is very kindly going to be my PowerPoint person today. So Paul, if you could pop to the next slide. Thanks so much. Okay, so just before I do anything, I would like to acknowledge the traditional custodians of the country throughout Australia and recognise their continuing connection to the land, waters and culture. I'd like to pay my respects to elders past, present and emerging and acknowledge this was, is and always will be Aboriginal land. So Paul has already very kindly given me a lovely introduction, but as he said, I am a paediatric registered nurse and my background is haematology oncology, but I have been a nurse for a long time. So I'm really delighted to be here and I do love educating families. And as Paul said, I'm happy to answer your questions as best I can. If I don't have the answers for you, I will find out and we will include those answers in the post-class email. So please feel free to ask any questions in the chat and I'll get to those at the end. Thanks, Paul. So just Paul's already done a lovely introduction about CPR Kids, but I just wanted to let you know that we are all paediatric registered nurses. We have a team of over 30 paediatric nurses, so we are a very lovely collection of knowledge between us. And basically, our mission is to empower parents and carers with the life-saving skills of baby and child CPR and first aid. So it's so important. We know what you do in the moments before an ambulance comes will make a huge, huge difference to the outcome. So that's what I'm going to teach you today. Now, if you would like to follow along with me, I'm going to be showing you my mannequins and what to do. If you would like to follow along with me, I encourage you to grab a pillow or a teddy bear or a dolly, something, and actually have a practice with me. We know that the more you practice, the more likely you will be successful in a real situation. So please feel free to practice along with me. I really, really encourage you to do so. Perfect. So as Paul has already mentioned, you will get some post-class resources, fact sheets, videos and whatnot. So please look out for that. That will probably come into your email sometime tomorrow or the following day. We also do have a Facebook page. So I encourage you to have a look at that. Facebook is a really, really good place to check out some of the stuff we do, and we use Facebook as an evidence-based resource for you. So really great info. You can also are welcome to always ask us questions through our Facebook page as well. I know the PowerPoint's dropped off there.
I don't think I can have it.
Perfect. Thanks so much, Paul. So we're going to cover CPR and choking today. Now I'm going to go through this all. This is just like Paul said, a snapshot. Obviously, we do it in much more detail in the classes, and in the classes, there's lots of hands-on practice as well. And we can also adjust your technique based on your specific needs in the classes as well. So we can do that, but that's what we're going to cover today. And like I said, I do encourage you to practice along with me. Thank you. All right, so what is CPR? For those of you who don't know, CPR stands for cardiopulmonary resuscitation. So cardio means your heart, pulmonary means your lungs, to resuscitate, to revive. Now, having said that, it's not like you see on TV. So you know on TV, someone will collapse and someone runs in, I'm a doctor, I know what to do, or they do a couple of compressions and the person wakes up. It's really important that you know we do not expect your child to regain consciousness in the middle of your CPR. It's possible they'll wake up in the middle of your CPR, but it's very unlikely. Most likely they're going to wake up later in hospital. You need to know that because it's very common, parents, if they've started CPR on their child and they're expecting it to be like the movies, they're expecting the child just to spring back to life after a little bit of CPR. And that's really not common at all for the child to wake up in the middle of CPR. Possible, but not common. So the purpose of CPR is to take over the pumping action of the heart. You become the pump. So some of you may already know the brain can last about 4 to 6 minutes, so around 5 minutes without oxygen before you have irreversible brain damage, okay? But it takes around 10 minutes, sometimes longer, to get an ambulance in an emergency situation. So there's an overlap there where you're going to have brain damage occurring after 5 minutes, but about 10 minutes before you're getting an ambulance at least. All right. So what you're going to do in that time is you're going to pump the heart, take over the pumping action, and you're pumping blood and oxygen all around the body, particularly to that brain, to buy the ambulance some time. Okay. That is your goal. It is not your job to wake up the child. It is not your job to figure out what went wrong. It's not your job to fix it. It is your job to pump the heart, okay, keep that brain going until the ambulance can arrive. Now, any attempt is better than no attempt. I'm going to teach you today what you need to do, but come the time you're panicking and you can't remember, do something. The worst thing you can do is stand back panicking and do nothing, okay? You're just going to go hard and fast in the center of the chest and just do something, okay? Now, the next slide, this one here, thank you, Paul. Some people worry about the legal side of things. So people worry that if they get involved in an emergency situation and perform CPR, if things don't work out, they're going to be sued by family members and whatnot. So it is important to know in Australia, you're protected by law. As long as your intention is to help the person, you can't be sued if things don't work out. So it's worth knowing that and not letting that fear stop you from getting involved and helping someone who needs help, okay? So just keep that in mind. Now, you do need to ask consent. You can't just start CPR on a child if the parents have said, no, don't touch my child. And please don't do what they do on the movies, which is that, you know, Pulp Fiction, Adrenaline to the Heart, or a DIY trachea or whatever you see on the movies. You guys will be able to do the CPR, which we'll talk about shortly. Now, the next slide talks about age-appropriate CPR. So I'm going to be talking about babies and children. So babies or infants is 0 to 12 months and children is 1 to 8 years old. Excuse me. Once you're over 8 years old, you're in adult territory from a CPR perspective. Now, the differences are really minimal. So, for example, on the baby, we're going to do 2 fingers. On a child, we'd use 1 hand. On an adult, we'd use 2 hands. So certainly if you do have a child over 8 years old, you would be able to apply what I'm teaching you here today to an older child as well. So just keep that in mind. It's about if your 2-year-old is the size of a 10-month-old, you're going to perform CPR like you would on a 10-month-old. Okay, so go by the size, not the child's age. Okay, I'll talk about that a lot more later. So doctors ABCD, this is what I'm going to go through with you today. This is our 7-step action plan, and this comes from the Australian New Zealand Resuscitation Council guidelines. So that's who I'm following. Ann's core. They're commonly referred to as Australia, New Zealand. You're welcome to go and take a look at them. There's lots and lots of guidelines there. So that's where all this comes from, and it's all evidence-based. Okay. So our first letter stands for D. So the first D stands for danger. This is a really important one, and this is one that particularly gets forgotten by parents because your instinct in an emergency situation is to run in and fix stuff and help. And often you will overlook the potential dangers there. And we see this all the time. For example, people in the surf, the kids being dragged out by a rip, parents run straight in whether they can swim or not and often get themselves in trouble. So it's really important that you take a moment to survey the scene. Now, the group of people who get forgotten here are siblings all the time. So say you've got 2 kids, you're about to cross the road. One of your kids runs out and gets hit by a car. You've got your other kid there. If they're young, they may well follow you out into the road when you're running out there, and you don't want to be in that situation. So I really encourage you to just pause for a moment and think it through. Now, I do understand as a parent myself that, you know, the the drive to run into danger can be very strong. And I certainly, you know, I can understand if my son was in a burning building, I don't think I'd be able to help myself. I certainly don't encourage it, but I do understand that feeling of you need to get in there. So really think it through though. Don't run into a burning building if you've not called for help. Don't run into a rip without a flotation device, all those kind of things. You know, grab things and call for help and put those things in place before you do anything dangerous. And remember that you can't help someone if you're hurt yourself. So statistically speaking, the more people who are injured in an emergency situation, the worse the outcome for everyone. So if your child gets injured and then you also get injured, the outcome will be potentially worse for your child. So just keep that in mind. So D for danger, very, very important one that we don't want to miss. Our next one is R for response. So we've done D for danger, we've got R for response. Is the child conscious or unconscious? If your child is responsive, then they are conscious. They do not need CPR. They might still be very sick and need an ambulance, but they do not need CPR. If your child is unresponsive, then they are unconscious. They might need CPR. You have to continue down the steps to determine if that's what you need to do. Now, when I say responsive, got my mannequins here. This is baby Annie. Okay. Hello. Now, one of the ways I might know that baby Annie is responsive is she's going to move. Okay, so this is about movement and muscle tone. That's particularly what I'm looking for with a response. Are they moving intentionally, and do they have muscle tone? Now, obviously, if I pick up her arm and flops back down, that's not an intentional movement. I'm talking about intentional movement where they pull their arm away or lift their legs or scrunch up their face, any intentional movement, and also muscle tone. An unconscious person will be floppy, heavy like a rag doll, and nothing you do to them will make them move. Okay. So with a baby, when we're determining a response, we're going to hold the baby nice and close. We're not going to shake our baby, and we're going to give her him or her a firm tickle. Okay. You can blow in her face. You're trying to get her to do that, scrunch up her face or something, any kind of intentional movement. Okay. Say her name, Annie. Annie, open your eyes. Open your eyes, Annie. If she's floppy, heavy like a rag doll and you cannot make her move, she's unconscious, and you move on to the next step. Now, with our older children, it's exact or very similar, but we're probably not going to pick up our older children. So older children, statistically speaking, are more likely to be unconscious because of an injury. And we know that if they've got a nasty injury, potential spinal injuries or something like that, we don't want to move them if we can help it, okay, unless they're in danger. These all take priority, okay. So with the older child, you're going to go over to them and you can pinch the top of their shoulders. So you can tickle the ribs firmly, a bit scratchy, and pinch the top of their shoulders. Feel free to do this with me. Pinch the top of your shoulders. That's where you're going to pinch, just up here, this muscle. You can give yourself a nice massage while you're there. That's where you're going to pinch, okay? The same thing, you're going to say their name. This is Tommy. Tommy, Tommy, open your eyes. Tommy, look at me. Open your eyes. Tickle his ribs. Pinch his shoulders, okay? If he's floppy, heavy like a rag doll, you cannot make him move. He's unconscious, and you move on to the next step. So we've done D for danger. We've done R for response. Our next step is S for send for help. So 000 is the number to call. Please try and call 000 in Australia. 911 possibly will work. People call 911 so often that some smartphones will now redirect you because it happens so often, but I cannot guarantee that. Depends on your phone, your service provider, a whole load of factors. So 000 is the number to call in Australia. Now, if you're overseas or 000 is not working for you, 112 from your mobile phone is the number to call. Okay, so if you're in a country where you don't know emergency services, the number, or 000 is not working, you can call 112 from your mobile phone, and that will put you in touch with local emergency services. So a great number to keep in the back of your mind or save into your phone is 112. Now, this app here, Emergency Plus, we're going to send you a link to this app. I'll just show you on my phone. This is a really great app. It's free to download, and I do encourage you to have it because it actually, I don't know if you can see, it's a bit hard with this light. It gives you your exact latitude and longitude location. And down the bottom here, there are 3 words, okay, that appear. So that's what the screen looks like when you open it. 3 words down there. I could call 000, read out those 3 words, and they would be able to find me. So this is great if I was in the middle of a park somewhere and they say, call an ambulance, where are you? So I'm in the middle of a park, or where in the park. You could read out those 3 words and they would be able to find you based on the 3 words that you say, okay? So really, really useful app to have. The other thing about this app is when you click up the top and go into more information, it gives you tons and tons of other numbers. So the Poisons Helpline, Health Direct, which is like a nurse on call. I think in other states, it's sometimes called nurse on call. So those kind of numbers. The non-emergency police, Lifeline, lifeguards, tons and tons of numbers are in here. Okay, so really, really useful app to have on your phone. And you can also teach kids, once kids can read and use phones, which happens quite young, my 6-year-old can already use it. You can teach your kids how to use it as well and how to call for help. So really useful app to have. Now, it's also really important. We know with children, a lot of accidents and injuries do happen in the home. You need to have thought through what you're going to do if one day you have an injury or accident in the home, you need an ambulance, but there's no phone. The phone's out of battery, you've left it in the car, anything like that, okay? So please have a think about who your best person is. Maybe it's your neighbor, maybe it's someone on the street, what you're going to do and who you're going to contact. Try and take the child with you where you can, unless there's a really nasty injury, potential spinal injury or something like that. Try and take the child with you, because we do sometimes see parents in their panic, they run outside to get help, and because they're panicking, they lock the door behind them accidentally, or it just shuts and locks behind them, and then the child's unconscious and locked inside. We don't want that. So try and take the child with you if you can. And when you're screaming for help, it's help, help, I need an ambulance, call 000, my child. If you just scream out help, 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 people are very slow to get involved. So you want to be making that information that you're calling out specific. Help, I need an ambulance, my child, something like that. Okay. So D is for danger, R is for response, S is for send for help. Our next letter is A for airway. Now, little babies have an airway like this hose. Thank you, Paul. Like this, sorry, not this hose, this straw. A baby's airway looks a lot like a straw. It's very thin and very soft. It is very easy to kink. Okay, so baby's head drops too far forward or too far back, the airway can kink off very easily. By the time you're an adult, your airway looks a little bit more like a hose pipe. So much thicker, much stronger. It's still possible to kink, but much harder to do. Okay. So, and older children are sort of somewhere in between. So this step is really, really important in children because of how delicate and fragile that airway is. Okay. So what we're going to do, up to this point, we were running around calling for help, everything. We're now going to get to A to airway, A for airway. We stop and the child or the baby will go on the floor. They really need to be on the floor where possible, or a surface that's very stable and firm. Okay, you need the resistance of the floor or something firm to be effective. It's really important. Okay, now we'll start with the baby. Hopefully you can see my mannequin okay. So you're lying them on the floor. I'm just holding the mannequin so you can see, but you're lying them on the floor. The first thing you're going to do is look in the mouth. You're looking for blood, vomit, water, Lego, anything. If there's something in there, you're going to roll them on the side and brush it away. Now, if it's a lolly or a Lego or something like that, if it's right at the front, you're going to pull it out. But if it's at the back of the throat, don't go poking your fingers in there, okay? We call that blind sweeping, where you're sort of just aimlessly poking and rummaging around. The reason is because you can push that object or whatever it is further back and do damage as well. So we're going to leave that, and we can talk about that when we talk about choking, okay? If there's nothing in the airway, you don't need to roll the child. Right? Now, the next step, our babies need to be in a nice, straight, neutral position. So remembering our airways like the straw, if we have the head too far forward or too far back, we're blocking off that airway. So nice, straight, and neutral position, okay? What we're going to do with the babies is we're going to pinch. Get your fingers like that for me. I can't see you, so I'm going to trust that you're all doing it. I want you to hold your fingers like that. I want you to put your thumb on top, and I want you to put this finger underneath, and I want you to pull the chin forward. Okay, so I'm opening the mouth, but I'm also pulling the chin forward. Okay, so that is my good airway position for my little baby. Straight head with a little chin pinch. Okay, I'll show you the older child and then I'll play the animation in just a second. So that's our baby, straight with a little pinch. Now, the reason I'm pulling that jaw forward is because of the tongue. Okay, so that tongue goes floppy when you're unconscious, and it can flop back over the back of the airway. So by pulling the bottom jaw forward, the tongue is attached to the bottom jaw and it's pulling that forward as well. So that's why I'm doing this, okay, to move that tongue out the way to make sure it's not flopped over the back of the throat. Now, with the older child, we're going to have a head tilt. The older they are, we want that head tilted nice and far back, okay? So with this child, we're tilting the head. Same thing as before. If there's something in the mouth, we've rolled them on the side, brushed away. Okay, back on the back, tilting that head. And we need to do a chin lift, but the pinch won't be enough on our older child. We need a much stronger grip. So what we're going to do is hold your fingers like that for me. Your finger and your thumb should be pointed in the same direction. And you're just going to nuzzle your chin in between like that. Okay. So this finger's on the bone This finger's on the top of the chin like that. And I am tucked these fingers underneath and I'm pulling the jaw forward. So open, but also forward. And this is forcing the tongue to come forward and moving out of the way. So this plus a head tilt is my good position for my older child. Okay. So I'll just get Paul to play these animations. You can see this first one. I'll just talk through it. If you can play, thanks, Paul. You can see the baby's airway was kinked and it was all blocked off. I straightened that head. I pinched that chin up nicely and air is able to flow. Okay. So that's what we're doing. With the older child, again, you can see the tongue is flopped back and the head's too far forward. So we tilt that head back. It goes much further back than the baby. And that strong jaw lift allows air to flow. So that's what we're trying to achieve with this. Okay, so that's our step A. A is for airway. Excellent. So D for danger, R for response, S for send for help, A for airway. Our next step is B for breathing. Okay, this is where we're going to look, listen, and feel for breathing. Okay, we have 10 seconds to decide. That's it, 10 seconds. If we cannot decide in 10 seconds if our child is breathing normally or not, then the answer is they're not breathing or not breathing enough, and we move on to the next step. Okay. Now, obviously, if you can already tell straight away just by looking your child is not breathing, don't wait 10 seconds. Just start with the next step. Okay. But you have a maximum of 10 seconds to decide. So you're going to look, listen, and feel. So you're going to get down nice and low to them, look, listen, and feel. You're looking towards the tummy. So you want to make sure there's no blankets and things. Expose as much as you can. Okay. You're listening for any breath sounds, you're feeling for breath on your cheek, and you're looking for any rise and fall in the tummy, okay, or the chest. Babies use their tummy muscles to breathe. Older children will move their chest muscles a bit more, okay? Really importantly, I want you to get to know what normal is for your child. How does your child look? How does your child breathe? What's normal for them? When they're well, what do they look like? If you can identify normal, you can identify abnormal, and that's really, really essential. Okay, so take the time to get to know what your child looks like, how they breathe. What does it sound like? Is it loud? Is it quiet? What's normal for your child? That way you can clearly identify abnormal. And we're looking for abnormal breathing as well. It's not just no breathing. If a child was making that sort of noise and they're unconscious, unresponsive, we can't wake them up and they're making that noise, that's not normal. Okay, we're going to move on to the next step for that. Okay, the other thing you're looking for here is color. So Paul, I'll just get you to move on to the next slide. So color is really, really a great indicator in children. Children change color very, very quickly. Okay, my son actually, he choked. I'll actually tell you the choking story later. Sorry, my son actually lost consciousness in the lounge room. He had grabbed the TV remote from me, and he had like a blue episode, a crying tantrum kind of blue spell. He's screaming and screaming, and he became unconscious. And his color changed so fast. My son has lost consciousness way too many times. He became sort of this purple color, and then he went blue, and then he completely went floppy and unconscious. It happened so quickly. The color change was so quick and so dramatic. Okay, so children who are not breathing normally will not be a normal color. Excuse me. So you can see in this picture the child in the white circle with the blue lips, fingers and toes. Okay, this child is obviously not breathing normally because they're blue. That's not normal. Okay, but this child has muscle tone. They're conscious. This is not a floppy baby. This is a baby with muscle tone who's conscious. So this baby is sick. This baby needs an ambulance, but they don't need CPR because that is not a floppy baby. So to get CPR, they need to be two things: unconscious, floppy, heavy like a rag doll, cannot make them move, plus abnormal or no breathing. Okay, unconscious plus abnormal or no breathing. They need to be both those things to get CPR. All right. Now, if you have a child with much darker skin, those blue colors when they're not breathing properly can be a little more subtle. You'll notice them particularly around the tongue. So you can see this child with darker skin there has a very purple tongue. The tongue should be bright pink, bright red. It shouldn't be purple. But the key is, again, they will look different to normal. So get to know what normal is for your child or any child in your care. And finally, this picture here of the baby, excuse me, sorry, tickly throat. This picture here of the baby is mottled skin. Now, for some kids, this is very normal to have mottled skin. My son, for example, when he's very cold, he goes a little bit mottled, and that's normal for him. Okay. So for a healthy, well child, or if they're normally mottled, you don't really need to worry too much about it. Mottling is a concern when it's not normal. The child is unwell, perhaps they're unconscious, perhaps they've got fevers, perhaps they've been vomiting, got a vomiting bug, something like that, and then they look mottled. So mottling can be a sign of things shutting down. We often see mottling with nasty illness, sepsis. All right. So just worth keeping an eye on that. If it's not normal for your child to look mottled and they're sick and mottled, you would actually want to call an ambulance for that. Okay. And it's important that you remember the word mottled, because if you call an ambulance and say my child has a rash, that will prioritize very differently to a child who is sick and mottled. Okay. So just worth knowing that. But the key is know what's normal for your child, and children change color very quickly when they're not breathing normally. Okay. All right. So we're looking, listening, and feeling for breathing, and hooray, our child is breathing normally. So we now have a child who's unconscious with normal breathing. Okay. Now you can see this in a few circumstances. It's common after a seizure. It's common after a head injury. It's common if children have become unconscious with diabetes related things, fainting. We do see it happen a fair amount. Children are unconscious with normal breathing. And for these children, you need to roll them on the side. The reason we're doing that is to protect their airway, and this airway protection takes priority over any suspected injury. Okay. So we're going to roll them onto the side. If you're floppy and all your muscles are floppy, it's very easy to regurgitate, because all the muscles that keep your food in also become floppy. So it's really common to regurgitate. And if you're on your back, you can do what we call aspirate, which is where the vomit or whatever the fluid is can go into your lungs a bit. So the side position protects the airway and tries to prevent that as much as possible as well. With a little baby, you can just pick them up and hold them in that side position. So you want to make sure the head, feel free to pick up a pillow or a teddy and do this with me. You want to hold them in this side position, making sure the airway is not kinked. Okay. And if they're going to vomit, the vomit's going to come out. For the older child, we will send you a video on how to do this, okay? But the key is the how doesn't really matter. It's the get them on their side. So if they vomit, the vomit comes out, not down. That's it. How you get them there doesn't really matter, but we will send you a video with some techniques on how to do it, okay? So unconscious with normal breathing, recovery position. If they are unconscious with abnormal breathing, we are going to start CPR. So excuse me, the cold air is getting into my lungs. All right, so the C stands for compression. Okay, so danger, response, send for help, airway, breathing, compressions. We don't check for a pulse anymore. If you've done a first aid course a long time ago, you may have learned to check for a pulse. We scrap this step. If the child is, or the person is unconscious with abnormal or no breathing, if the heart hasn't stopped, it's gonna. And it's not about a heart that's not working. It's about a heart that's not doing its job properly. So the heart should be doing this. It might be doing this. And you feel that and you think, oh, they've got a pulse. That's not doing anything for their brain. Okay. So it doesn't matter. In hospital, if the heart's beating and we don't think it's doing a good enough job, we'll just pump over the top. It's not a big deal. The heart does not have to be pumping the heart does not have to be completely stopped for you to pump over the top. All right. So we're not going to check for a pulse. Now, a lot of parents are concerned that what happens if I'm doing CPR, I'm starting compressions on the chest and I break their ribs or break something while I'm doing it. And ultimately, it doesn't matter. If you were to break bones, we will have to fix those bones later. We can't really fix brains. So the priority is pumping the heart and keeping blood and oxygen going to that brain. That's what's essential with this. Okay. So with our compressions, it's the lower half of the sternum. The sternum is the chest bone right between the nipples. So I'll show you on my baby. You can see my baby Annie has nipples there. I'm going right there in the middle. Okay, that's where I'm going to press. On the baby, I'm going to use 2 fingers or perhaps 2 thumbs if that's more comfortable. On the older child, it's the same place. We've got our nipple line, 2 fingers, the hand right in the middle there. the heel of the hand for the child. You may well need 2 hands. That's very possible on a child, and definitely for a bigger child or an adult, you would need 2 hands. Okay. It's a third of the depth of the chest, which is quite deep. Okay. Now I'm just going to lower my laptop here a bit. Okay. So on my mannequin, I'm going down. Hopefully you can see that it's about 5 centimeters down, 4 or 5 centimeters down. On the baby, it's about 3 centimeters. So on the baby here, I'm pressing down quite deep. Okay. This will do nothing. This is CPR. All right. The research shows people don't go hard enough and they don't go fast enough. So if in doubt, go faster and deeper. All right. So a third of the depth of the chest, and the rate is 100 to 120 compressions per minute. All right. So that's about the same as row, row, row your boat. I'm clearly not a singer, obviously. Row, row, row your boat. Or baby shark, do, 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 do. I ruined your night. Sorry, you're going to have that stuck in your head all night now. So that's the kind of speed we're going to do. It's 30 compressions and 2 breaths. Okay, so 30 to 2, 30 to 2. So we've just given our 30 compressions. We're going to start with that. We're now going to give 2 breaths. Okay. So I might move through the next. I've talked through all these slides already. So there's some other songs. There's Baby Shark, Back. That's perfect. Thanks, Paul. Perfect. So we're now going to give the breaths. So 30 compressions and 2 breaths. And I will show you what this looks like in just a moment. 30 compressions to 2 breaths. Okay. I'm actually going to try and get you guys to practice with me as well. So I might play some music. So you're all going to have, I can't see you. I'm just going to trust you're going to do it. You're all going to have to get a pillow or something and have a little practice, or you can just do it on the air if you'd like to. So let me just show you the breaths first. Okay. Now we've done 30 compressions. Okay. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. I'm now going to give 2 breaths. Only 2. If my breaths are rubbish and they don't work, it doesn't matter. I go back to my 30 compressions and I try again the next cycle. So it's 30 to 2, 30 to 2. We're going to keep doing that pretty much till the ambulance arrives. Okay. 32, 30 to 2. So the breaths look like this. On the baby, your mouth goes over the top of the nose and mouth. Okay. Right. Your mouth over the top of everything. And it's about enough air to blow out a candle. Feel free to do that with me. Blow out a candle. That's how much air for a baby. Okay. For the child, your mouth just goes on their mouth. Okay. So you're going to pinch their nose on the child. So you're going to block off the nose so air can't escape. Your mouth will go on their mouth. You'll need to pull that head back with that chin lift. Okay. I might actually show you. Hopefully this works. My mannequins should be working. Let's have a crack. All right, so tilting the head, lifting that chin, blocking off their nose for the older child. Check. Hopefully you can see that little movement there, okay? Same with the baby. I'll show you the baby, all right? So baby's head is nice and straight with a little pinch. My mouth goes over baby's nose and mouth. For the baby, I'm blowing out a candle. For the older child, it's a much bigger breath, okay? Hopefully you can see that okay. Check. Check. I'm not sure if you could see, there was a little rise and fall there. It might be difficult to see on the screen, but that's what you're looking for. It's just a little up, down, okay? There's no need to overinflate the lungs. So in regards to how much breath to give a child, if they're half your size, give half your lung capacity. If the child is as big as you, give a full breath. It's whatever, you use your judgment. As long as you're seeing a rise and fall, even a little tiny one, that's enough, okay? So that's what we're doing, 30 compressions to 2 breaths, 30 to 2. So what I'm gonna do is I'm gonna show you what that looks like. And then I want to play a little bit of music just for 1, maybe 2 minutes and have a little practice, okay? So I'll just do it on the older child. So something's happened, okay? We run over to our child, and we know, oh my gosh, they don't seem to be moving. Something really bad has happened, okay? We panic because we're parents. That's what happens, All right. You think, oh my God, what do I do? You do doctors ABCD. I'll go through the last D in a moment. That's what we're going to do, doctors ABCD. How am I going to handle this? What do I do? The answer to that question is doctors ABCD. That's what needs to go through your head. Okay. So the first thing we do is D for danger. Is there any danger? Maybe there's people around that need to be moved. Maybe we're near a road. Maybe there's a fire. Make sure it's safe. Either get yourself to safety or make the space safe. Once that's done, okay, we check for response. So Tommy, open your eyes. Tommy, look at me. Open your eyes. He's floppy, heavy like a rag doll. We cannot make him move. He's unconscious. The next thing we're going to do is send for help. If there's people to help us, they can call. Make sure you know that they've called. If no one else is around, we're going to call and just put them on speakerphone. Okay. Help is on the way. The next thing is A for airway. So we're going to look in the mouth. We're looking for our blood, vomit, water, Lego, whatever it is. If there's something in there, we roll and brush away. Okay. We could pull it out if it's nice and easy. Otherwise, we leave it. Back on the back. The other thing with airway, with our older child, we want the tilt and the jaw lift. With the baby, we want straight with a little pinch. Okay. For the older child, tilt with a jaw lift. Okay. So that's A. The next step, B for breathing. We're going to get down nice and low and a maximum of 10 seconds. We're going to look, listen, and feel for breathing. And I can already tell Tommy is not breathing normally. So I'm going to start CPR. All right. So I'll get myself in a good position. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Breath. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Breath, and so on, so on. I'm going to keep doing that. Okay. So I'm going to play a little bit of music just for a moment, just for 1 minute. You'll grab a pillow or something. I'm going to trust that you're all doing this. Otherwise, I'm going to look like a Wally, just sitting here doing nothing for a minute. I'm going to play some music, and I want you guys to just grab a pillow or anything and just get that rhythm. Okay. I can get my thing to work. I'm going to play Baby Shark. It's going to drive you bonkers. So you may as well do something, otherwise you'll go mad. Okay. So grab your pillow and just have a feel of that rhythm. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Breathe and breathe. Okay. So that's the pace. Either you were doing that or maybe you were just dancing. Either way, it's fine. We're doing that 30 to 2. Okay. When do we stop? Now we've got the last letter D, which I'll go through in a moment. When do we stop? You can see this slide here. If the child starts responding. Now it's very unlikely, but it is possible that in the middle of the CPR, this child will start responding. Okay. So they're not talking about breathing. All right. I'm talking about responding. If you notice them breathing normally on their own, of course, stop and roll the child on their side. It's most likely that you won't notice until they completely, either an ambulance arrives or they start fully responding and pushing you off. Roll them straight on their side, okay? Because the next thing that's going to happen is a big vomit. We want to make sure that vomit comes out. If the ambulance arrives, most common time you're going to stop. If you are too exhausted, now with your own kid, if you had to do an hour of CPR, you just do it, okay? You get this sort of like super strength. You would be able to do it, I promise. But if you were alone, you know, maybe there's been a car accident, you're doing CPR on a big footy player size guy, you're on your own, no one's coming to help you. At some point, you're going to fatigue, and that's okay. Do the best you can for as long as you can. If you have to stop, that's okay. A reliable person takes over. So maybe someone else with first aid training can come and help you. Maybe, you know, a doctor shows up. They say, I'm a pediatric intensive care specialist. Can I help you? Yes, please come and help me. Great. Okay. So let people help you. In hospital, we do 2 minutes, which is about 6 rounds. If you're doing 32, it's about 6 rounds of 32-ish, gets you to about 2 minutes. Okay. Don't get caught on that. Go for a while, and if there's someone who can help you, swap out. You'll need those little breaks. It is exhausting, even on children. CPR is exhausting thing to do, okay? The final reason you will stop is if the defibrillator tells you to. Now, I'm just going to touch on, so the last letter stands for defib, defibrillator, AED. It's called a few different names. Get familiar with these names, defib, AED, defibrillator. It's one of the first things the ambulance will ask you for when you call them. Okay, do you have a defibrillator? These are everywhere. Okay, pubs, clubs, shopping malls, schools, swimming pools, they are absolutely everywhere. If you have one nearby, use it. Okay, please don't be afraid. They are designed so children can use them. All right, I know they seem a bit scary and foreign, but if you're in this situation, grab one, turn it on, follow the instructions. It will talk to you and tell you what you need to do. Okay, they can be used on children. They can be used on any age. So don't be afraid. It will not let you shock unless it needs to shock. Okay, that's its whole job, is to know what the heart's doing. So it's not like the movies where someone's on a heart monitor and then they flatline and people come in and give them a shock and then it starts the heart again. It actually doesn't restart the heart like that. What it does is the heart should be doing this, and for some reason it wobbles, does a bit of jelly on a plate. We give it a shock and it does this. But the machine knows what the heart's doing. The machine knows if the heart's doing this, or is the heart doing this, or has it stopped? It will know. Okay, so please feel free to use them. All right. Basically, if you can go to the next slide for me, Paul. So basically, you can just pop the pads on, follow the pictures. Okay. We do go through this a lot more detail in the class, but ultimately follow the pictures, and it will say something like analyzing rhythm, stand clear. So you've plugged it all in, you've turned it all on. When it tells you to, you'll stand clear, and it will say something like shock required. Press button to deliver shock. Beep, shock delivered. Continue CPR. And then it will give you a little tone. Beep, 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 to help you keep time. You press, okay? Remember to give the breaths as well. Then it will speak to you again. Analyzing rhythm, stand clear. Everyone hands off the child, okay? It might say no shock required. Continue CPR. Beep, beep, beep. You go through it for another couple of minutes. Analyzing rhythm, stand clear. CPR is not required. Roll patient into recovery position, okay? So that's kind of how they work. It'll talk to you. It's very easy. You stick the pad straight onto the skin, and I encourage you to use this. If don't stop CPR to go and find one of these. If there's one right there, use it. Or if you've got multiple people, send someone to go and get one, okay? But if it's just you on your own and there's no defib near you, forget this step. You're just doing the CPR, okay? So that is in summary. That's a very quick little summary of Doctors ABCD. Obviously, when we do it in class, we go through it in much more depth, but that's just a little snapshot to give you an idea of what you could do, what you would need to do in an emergency situation, okay? Now, I do know there are a few questions, but I'm just going to talk about choking quickly, and then I will definitely spend some time coming back to that, back to your questions. Now, Paul, am I good for time? I did notice that it said the meeting is coming to time-wise. Am I good to keep going? Hopefully I'm all good. Let me know, Paul, if it's going to cut us out or anything like that. Hopefully it won't. Okay, so choking. We'll just talk about this really quickly. Now, there should be a little x-ray picture. The next slide, it should be an x-ray picture. So you'll be able to, it's a side-on view. You can see the black tube there is the airway, and that round thing, that is the blockage. So this is a choking child, okay? Choking basically means there's a blockage in the airway and air can't flow properly past that object. So this has made a complete blockage. This is actually a grape stuck in an airway. So you can see how it makes that complete blockage there. So when it comes to prevention of choking, We're going to chop up food appropriately, okay? Whatever is appropriate for your child depends on their age, and it might depend on if they've got disabilities and things, but make sure you're serving food appropriately for your child. It's really, really important. We know those rounds, those sort of solid round shapes can really cause those nasty blockages. So like this pictures, you want to chop up grapes in quarters, ideally. Carrots in sticks. We don't want those round shapes. Sausage, in terms of food, sausage is actually one of the most common choking hazards resulting in fatality because it often gets chopped up as that round shape, that airway size and shape. Okay, so we want to be really careful with that. Also be careful with foods such as popcorn, which can really cause a lot of problems. It can irritate. If it gets stuck, it can sort of break up and go into the lungs. Popcorn's quite a risky one, and we don't really recommend children have it until they're about 5, school age, before they have popcorn. And same with toys as well, making sure little bits of Lego and coins, even deflated balloons. There was actually a study which listed deflated balloons as the #1 choking hazard as well. So please be careful with that. Generally speaking, if it can fit through a toilet roll, it's a choking hazard for the child. Okay, so that's size-wise, which is bigger than people think. All right. So if you're, especially for your little babies, if you're baby-proofing your house, factor that size into when you're deciding what toys and things your kid could play with. And with food, you need to prepare it properly. Children need to be sitting down, and supervision is essential. Choking can be very quick and very silent. So if you're watching your child while they're eating and they choke, you can respond quickly. The quicker you respond, the better the outcome. Okay. So gagging as well, we need to talk about that quickly. Gagging is normal. So gagging is a reflex at the back of the throat. Something hits the back of the throat, the tongue thrusts forward, the cheeks go red, the eyes might water, and they do that sort of vomity face. But gagging is normal. All children gag, some more than others, but it's very, very normal. It's actually the body's way of protecting the airway. Okay, so generally speaking, gagging is nothing to worry about. Just make sure the child's sitting up and let the reflex do its job and push the food out if that's what needs to happen. They might even vomit, okay? Choking is different though. A child who's choking will likely change color, so turn purples and blues and things like that. They'll start red and then turns purples and blues. They look really terrified. My son actually choked on a marshmallow in a cafe. I ordered him, he was about 2 years old. I ordered him a baby chino and he started choking on a marshmallow. I never would have let him have the marshmallow. The waitress put the cup in front of him and he just grabbed it and shoved it in. And he's sitting forward. He's gone this purple color. He's got these, I've never seen fear like it. He was so scared, these wide eyes, open mouth. I could see it in there, pink marshmallow. I'll never forget it. It's just too far back for me to get. And he was doing this weird head bob, like he was trying to cough, but no sound was coming out. I knew straight away he was choking, got him over my lap and did some back blows, which I'll show you. Unfortunately, it came out. So children will change color. They look scared. Babies will drool. I'm not talking like teething drool. I'm talking it will pour out their mouth. So drool is really common. Sometimes they can make a little bit of noise. So the cry can become very high pitched. They can have whistly, wheezy sounds. They can have stridor kind of sounds. That's a kind of stridor sound. But consistently is the color change and the fear. Okay. So what are we going to do about it? If they have a good, strong, effective cough, so the child is choking, something's stuck, but they are able to get some air around it because you've chopped it all up and they can cough. For that child, we're going to sit them up, lean them forward and encourage them to cough. Okay. So good girl, Annie, big cough, good coughing, Annie, cough like this. If she can't understand you, she might mimic you. Okay. You can give her a little rub on the back. I'm not going to hit her if she's got a good, strong cough herself. And the reason is if I hit her and move that object as she takes a breath in, I could then actually make that object go down further. Okay. So good, strong cough, encourage them to cough. Good girl, big cough, good coughing. Same with the older child. Lean them forward if you can. Good cough, big cough, good coughing, Tommy. Well done. Big cough, well done. Something like that. Okay. Now, if they're choking and they have a weak, rubbishy cough, so instead of it might be there's no power behind it, or there's no sound at all, then we're going to intervene. Okay. Now, with a small child or a baby, you're going to get them over your lap. Paul, if you can just go to the next slide for me. You're going to get them over your lap. Now, here's a few examples of how you might hold them. Okay. Ultimately, how you hold them doesn't matter as long as it feels safe for you. Okay. So if they're small enough, we want them tipped upwards. Okay, so gravity will help. So not flat, they're on a bit of an angle. All right. I like to hold them off to the side, but off to the front like that picture as well is also fine. I like to pop their tummy on my leg, tip them up. We're going to do up to 5 back blows. Now, call 000 first is important. If you forget, there is another opportunity to call, but try and call 000 up front. Just pop them on speakerphone if you're on your own. Okay. We're going to give up to 5 back blows between the shoulder blades. You must hit between the shoulder blades because we're hitting firmly. If you hit too low, you can hurt them. So up nice and high. Okay. We're going to go 1, and then we check. It's important to check. We don't want to just hit the child over and over again because it might come out and then you're hitting for no reason, which we often see parents do when they're panning. So hit, then check, then hit, then check, and so on. Okay. 2, check. 3, check. 4, check. 5, check. We're going to do 5. Obviously, stop if it comes out. Okay. If you got to 5 and the child is still choking, we're then going to flip them over. Make sure you've called 000. Things are getting serious now. If you haven't, you need to stop and call 000. Okay. We're going to hold them like this, same in this downwards position. Okay. And we're going to do a chest thrust, which is similar to a compression. So we're pushing on their chest. We hit the back, we push the chest. Okay. So 1, check. 2, check. 3, check. 4, check. 5, check. I'm checking to see if they're still choking. Okay. Notice I'm bringing myself down to check. I'm not bringing the child up. Okay. Put yourself down because otherwise things can get confused. All right. And we keep doing that. 5 on the back, 5 on the front, back, front, 5, 5, 5, 5 until the object comes out, the ambulance arrives, or the child becomes unresponsive and floppy. The second that happens, they become floppy and unresponsive. We stop all this. We put them on the floor. We start CPR. We still give those 2 breaths, even though we know there's an object stuck. Okay. The reason is some air might get around that object, in which case that's great. A little bit of air is better than none. It's also possible if we do push that object down into one lung, well, we've freed up the other lung. That's also okay. All right. So it still give those 2 breaths. The older child is exactly the same process. It just might change the way you hold them. So if they're small enough, like this picture on the end there, with the sort of orange, navy blue stripes, get them over your lap if you can. Once they're too big for that, stand them up, lean them forward, but it's the same process. Okay. So 000, if they've got an effective cough, encourage them to cough. Good boy, Tommy, big cough. Weak, rubbishy cough or no sound at all. We call 000 between the shoulder blades. 1, check. 2, check. 3, check. 4, check. 5, check. Remembering if we haven't called 000, we must stop and do it now. Then we do chest thrusts. So the push on the chest is the same place we just taught the CPR, that nipple line on the bone. You must be on the bone. Lean them forward, the heel of your hand, and pushing in there to the chest. Okay. You might need to push them up against a wall or into a chair to help get that leverage. I know it's not very nice, but it might be what has to happen. Okay. Finally, if you needed to, you could do the chest thrust in this position. Now, let me be really clear here. This is not the Heimlich maneuver. The Heimlich maneuver is a press on the tummy. It's an abdominal thrust, and we have removed it from the Australian New Zealand Resuscitation Council guidelines, okay, because people were having some internal bleeding that was happening when they were having the tummy pressed. So we don't press on the tummy. We don't do the Heimlich maneuver. But if you need to do a chest thrust, you've done back blows, you need to do a chest thrust, but the only way you can do it is by hugging your child in this position. That is okay, but make sure you're on the bone. You must be on the bone between the nipples, okay? So fist, you can make a fist and do your chest thrust like that. So that is okay as long as you're on the bone, not the tummy, okay? So that is a little snapshot. Obviously in classes we go through it in much more detail and you get lots and lots of practice, but that is a little snapshot. So now it's time for some questions. I know there were some questions in the chat, so Paul, I might hand over to you to organize the questions.
Yeah. Okay, can you hear me?
Yes, I can hear you. Yeah.
Okay, thank you guys, and big thank you to Jessie for that presentation and for persevering. Teams is not playing with us tonight, guys. It's not behaving for us. So we've managed to get through, and Jessie kind of did that presentation somewhat blind there. So thank you so much, Jessie. That was very, very informative. I learned something new. I just did CPR course formally, and I even learned. I can't believe the thing about the sausages and cutting up the sausages. The amount of time I've cut up my children's sausages for dinner in that very way. Oh, I feel bad. Anyway, thankfully I haven't had an emergency.
Oh,
But thank you. We have got a few questions that have come through, and I'll start at the top and we'll make our way through them. I'm just conscious of the time, so we don't have a lot of time here. But guys, if you are still online and you do have a question, quickly pop it into the chat and we'll get through these as soon as we can. And then we'll get on our way for the evening. All right, first of all, Grant said, I might have missed it, but was there a link for the app? You will be sent a link for the app, but what was it called, Jessie?
So the app is called Emergency Plus, so you can just download it on the App Store. It's free, but we will send you a link in your post-class email, which should come through to you tomorrow or the next day.
Yeah, great. Thank you for that. All right, here's a question from Lauren. She said, a few years ago, I did a CPR course and was told the same thing about 30 compressions to 2 counts of breaths. A few weeks later, I had to do CPR on my father-in-law who had a heart attack. The 000 emergency responder kept counting to 10 on repeat. I remember feeling really confused and asking about the breaths, and the 000 responder kept ignoring me and just kept counting on repeat. I felt like I had conflicting advice. It had me hesitating about what I was doing. Do you know why a responder would not be saying to do the breaths?
So I do, and that is to do with being an adult. So what they have looked at now, especially COVID has sort of fueled this research particularly, although it did come in before COVID, is that adults have about 10 minutes worth of oxygen reserve, okay? Children do not have this oxygen reserve. So any child or any person who has drowned, the breaths are essential. But a typical adult where you've sort of witnessed things happen, they do have about 10 minutes of oxygen reserve. And what the research showed is people get sort of flustered by the breaths. They don't always do them that well, especially if they've not had the practice with them. So you can actually omit them from adult CPR. So it's called compression only CPR, but it's only under certain circumstances with adults. It'll never be the case with children. The breaths are essential on children or anyone who has drowned.
Okay, great. I'm not going to get this name right, but Padmashri has asked, some say we might break the rib cage if we put too much pressure. Is this true? Should we really give this a try without having practical knowledge?
So yes, children have very bouncy bones typically. So it's actually very unlikely you will break the bones in a child unless the child has some condition where they've got perhaps brittle bones or something like that. With an adult, yes, breaking the ribs and bones is definitely a possibility. What it comes down to is that we can fix bones. We can't fix brains. So it's about the priority is the heart and the brain. So pressing on the chest, even if you were to break those ribs, the priority is a good firm compression with full recoil, which is where the chest bounces right back up to allow that heart to, it empties as we push and then fills back up with blood and then empties, and that creates the pressure which goes ideally all around the body, particularly to our brain. So it's all about priority. Yes, you might break ribs, but it doesn't matter. Don't let the fear of breaking ribs hold you back from pressing hard enough on the chest. It needs to be hard and fast.
Okay, great. Guys, just a quick reminder, last chance to submit a question in the chat. We've got a couple to go and then we'll be calling time on the session. So I've got 2 more here to fire to you, Jessie. Have you heard of the Life Vac devices? They look like an oxygen mask and there is a simple plunger kind of pump which attaches and you are meant to be able to suck the blockage out. They sound like such a great device. I'm just wondering if the medical community have heard of them and whether or not they are a gimmick or legit.
So yes, LifeVac or the other brand that's circulating is D-Choker. So both very similar devices in how they function. Yes, we have all heard of them. And are they legit or a gimmick? The honest answer is we don't know yet. The research has not been done. It's certainly not adequate research to put them into the guidelines. So we just don't know. I certainly can't recommend them at this stage. Once the research comes out, if they prove to be effective, then great, they'll probably be put into the guidelines. I do urge you to consider, though, if you had one of these devices, it's probably going to be tucked up in your first aid kit. And if you think about your child choking, you're leaving your child to go and find this device, which you're panicking, and it's sort of tucked up in a bag. So the skills I've taught you today are really important with the back blows. Even if the LifeVac or the D-Choker or those kind of devices do come in, they will be used most likely as an adjunct. So one person is doing the back blows while a second person goes to fish it out of the first aid kit and things like that. So at this point, the evidence, we just don't know if they're legit or a gimmick. We just don't know yet. But watch this space. They're making headlines.
Okay, great. Padmistry also asked, where would the food or piece of thing that may be stuck in the throat go if you're giving them CPR?
So it could go in a couple of different places. It's possible if it's stuck in the throat and they're having CPR, it could come up. Okay, so that's possible. As you're putting that pressure on the chest, it creates that puff of air, and then it could eventually come up, hit the gag reflex and come out, or if they have a bit of a vomit, it could come out. So that's one possibility. The other possibility is it could go down into one of the lungs, usually on this side because of the way the anatomy works. And that's also okay because then we've freed up another lung. The other option is it won't move at all. Okay, so we just don't know. And because we can't see what's going on inside and where it's going, we just carry on as best we can. Okay, does that hopefully answer that question?
Yeah. Okay, great. Thank you for that. I've got a couple of things. I can see a couple of things being typed at the moment, so I might just fill you in. You may have seen that final slide come up, but as I mentioned at the start of the presentation, we do have some, well, CPR Kids full stop has courses on all year round, weekends, weekdays, also in local areas. We do have, through our new relationship with CPR Kids, a couple of sessions coming up in our NAPA clinics. So for those of you who are familiar with NAPA and are close to our Sydney or Brisbane clinics, we do have a Sydney session coming up, which is about a 3-hour course on Saturday, the 19th of August, 1 till 4 p.m. And the Brisbane session is on Saturday, the 9th of September, 1 till 4 p.m. So again, we will send you out an email tomorrow with a couple of links that Jessie has spoken about tonight, a couple of videos, a bit of information, and the links, and as well as the discount code for registering for those courses, which are more in depth, cover all aspects of first aid and CPR, and will give you a more thorough understanding of the principles that she's given you a top line information on tonight. So please look out for that email in your inbox over the coming days. As I said, there are a couple of things coming up. Please remember, we've got a paint and sip night coming up with NAPA, so you can get on Eventbrite and get your tickets to that. We've got a night about siblings and raising siblings, or how to look after the siblings of children with disabilities. That's coming up with Kate Strom from Siblings Australia in September, so you can get your ticket from that on Eventbrite as well. We've got an open day happening in our brand new Brisbane clinic on the 2nd of September. And don't forget, intensive registration is on the 28th to the 30th of this month. So that's end of next week. Final questions. Well, I've got a big thank you. So big thank you so much. The session was very engaging and informative. Great work. Thank you. Got a question from Alex here. How do you hold an older child who cannot walk or sit with choking?
So that's a really, really great question. And the simple answer is ultimately however you can, really. So what you need to be able to achieve is those effective back blows is where we're going to start. So You're ultimately going to hold them however you can. Ideally, if they can be in a position that is leaning slightly forward, okay? And then you need to be able to hold them in a position where you can deliver a firm back blow. So how that looks for you and your child will ultimately depend on your child, what they can and can't do, and then your own physical strength as well. It might be that you need a second person to help you. So one person's holding and one person doing the back blows. So don't get caught up too much on the how to do it. There is no hard and fast rules on the how to do it. It's however you can do it, really. So I hope that answers your question.
Great. All right, Jessie, I think we've got a couple more thank yous. So Kate says, thank you, Paul and Jessie. Fantastic presentation, very helpful. Casey says, thank you. I'm leaving this session feeling way more confident. Much appreciated. And that ultimately is what we're hoping for, guys. You know, just a little bit of education out there, just a little bit of information to help you if this situation ever does occur in your household or near to you. So a big thank you to Jessie from CPR Kids. That was fantastic. You explained it in a very attainable way, and it was really great to have that. I just got a question through. Yes, we will be able to access the recording. A link to the recording will be sent through in the information that we sent out. Yes, I can see you missed the first half because your child's bedtime, and that's perfectly understandable. We will send out a link to the presentation as well as all those other things that we promised either tomorrow or the next day. So big thank you to Jessie from CPR Kids. Remember, you can see her all the listings and courses and information on cprkids.com.au. Big thank you for everyone for attending tonight, and good evening from NAPA and CPR Kids. Thanks, guys.
Thank you.